Alright, y'all, let's talk about warfarin. Warfarin is a blood thinner. It basically blocks the formation of vitamin K-dependent clotting factors, as well as protein C and S. The exact mechanism of action is that it blocks vitamin K epoxide reductase complex subunit 1, or VCORC1. This enzyme is genetically polymorphic. We're gonna go back to that. This enzyme helps with the formation of active vitamin K. Vitamin K basically helps form active clotting factors. So genetic polymorphism, I've briefly talked on my page about before. This basically means that this enzyme can be either overfunctioning or underfunctioning in certain people. That's important because if a patient is initiated on warfarin, sometimes they might need a higher dose or a lower dose. If you're interested, you can go to CPIC's website. CPIC stands for Clinical Pharmacogenetics Implementation Consortium. This is an organization that provides evidence-based guidelines on how to use genetic information to optimize drug therapies. Here we can see VCORC1 and warfarin. And if you're interested, you can pull up the article and look at the different polymorphisms and how they're correlated to different ethnic groups, and then they're given recommendations based off of that. All right, let's do a quick little overview of warfarin. Warfarin's onset is 36 to 72 hours, so it takes a couple days before we start seeing an effect on the INR. It is highly protein bound. This is important because some drugs can displace protein binding. We can also see some variability with patients that have disease states that affect the levels of albumin. Its half-life is 20 to 60 hours, so it can stick around a little bit. It's a racemic mix, so the S isomer is actually 5 times more potent. If we look down here, this S isomer is primarily metabolized by CYP-C9, so this enzyme is a little bit more important than these other two when it comes to drug interactions. This is very important, but the full therapeutic effect is not seen until 5 to 7 days after initiation. This is because of the half-life of clotting factors. Remember, we're basically blocking the synthesis of active clotting factors. We gotta wait for those other active clotting factors to die off. This is why patients need to be on a parenteral agent first, because if there's an indication to be on a blood thinner immediately, we can't wait for 5 to 7 days. I'll also mention warfarin inhibits the synthesis of active protein C and S. These are two little proteins that are actually part of the body's natural anticoagulation. Because of the shorter half-life on this anticoagulant, we can see a temporarily hypercoagulable state before these other little clotting factors degrade. Another reason why it's important to be on a parenteral agent. Generally, we're going to start patients on 5 milligrams daily and have the general INR goal of 2 to 3. I will mention that it's a little higher of a goal when someone has a mechanical mitral valve, 2.5 to 3.5 about. There are certain disease states where we would want to start someone off on a lower dose. For example, with liver disease, if someone's not adequately producing clotting factors, they might have more of a response to warfarin. So there are going to be some other things, again, that influence the dosing. Like if they're older, what their social history is like. For example, if they're smoking. Smoking can increase the metabolism of warfarin. Some studies show that smoking was associated with a 13.21% increase in warfarin dosing requirements. So because it's inducing enzymes and increasing the metabolism of the warfarin, we're going to need it a little higher of a dose. For its side effect profile, of course, bleeding. Some patients are at a higher risk for this. I will mention that the Amplify trial looked at the difference between Eliquis and warfarin. We saw that Eliquis was non-inferior with regard to its primary endpoint, meaning it was just as effective at reducing the risk of recurrent VTE or death secondary to VTE. However, Eliquis was superior with regard to major bleeding. The Einstein trials basically showed the same thing, but with Xarelto versus warfarin. There's some other rare side effects for warfarin. You can pause and read if you're interested. Let's look at things that are going to decrease your INR. Remember, INR basically tells you how fast blood is clotting. If the INR is decreased, that means that the blood is clotting faster. So you're going to have to increase your warfarin dose if it's not in range. So medication that can decrease the INR with warfarin is cholestyramine. This can decrease the absorption of warfarin in the gut. Again, I mentioned smoking. It's going to increase the metabolism of warfarin, and also drugs and medications that increase the activity of 3A4, like rifampin and carbamazepine. I will also mention that exercise can decrease the INR when you're on warfarin. Exercise doesn't have like a ginormous effect, but I thought I'd mention it. Of course, if you gobble up a bunch of vitamin K, that's going to decrease your INR. So it's very important to have a consistent diet, of course. I mentioned on my page before that mayonnaise has a little bit of vitamin K in it. This has to do with egg yolks. Things that are going to increase the INR. So increase the time to clot, make your blood a little thinner. We have 2C9 inhibitors. Remember, the S isomer is metabolized through 2C9. It's 5 times as potent as the R isomer. I call this the Fab4. So F stands for Flagyl, A stands for amiodarone, B stands for Bactrim, and the 4 starts with an F, fluconazole. Even a single dose of diflucan can affect the INR. It's a strong 2C9 inhibitor. And it also has a half-life of up to 50 hours. Some 3A4 inhibitors are going to affect the INR as well. Antibiotics can as well because it depletes vitamin K producing bacteria in the intestine. Be careful with patients who are on other blood thinners or antiplatelets. These are called the 3Gs, garlic, ginkgo, and ginger. These can thin your blood a little bit. And then conditions that decrease the clearance of warfarin or increase the catabolism of clotting factors are also going to increase the INR. I'll mention the reversal agent is legit vitamin K. There's a bunch of patient education with warfarin, so be sure to explain to patients why they're on a blood thinner and what the expectation is with how long they might be on it. Make sure they're aware of how to bridge this. Counsel them on the signs of bleeds as well as the signs of a blood clot or PE. They need to be aware of drug interactions and checking with their pharmacist when they start any over-the-counter herbal products. They need to be aware of the importance of consistency, especially when it comes to diet. They need to be rather health literate and they have to have transportation to go get their INR checked frequently. I guess you can tell them that the color of the tablet changes with the strength. Counsel them on how to navigate missed doses when they forget to take a dose. Warfarin was pregnancy category X, so don't really get pregnant. Polypharmacy is always an issue with like everything it seems, but make sure they're picking up their scripts at one pharmacy so that drug and condition interactions will flag on the profile. Pharmacists will be able to catch that. I mentioned bridge therapy, but this is when we use a parenteral agent while we're waiting for the warfarin to take effect. Usually patients will be on Lovenox or enoxaparin for about 5 days until the INR is therapeutic. The term bridge is also used when we put them onto a shorter acting blood thinner for an invasive procedure, surgery. So again, we might want to start at 5 milligrams, but consider a lower starting dose when a patient's at risk for higher warfarin sensitivity. So severe hepatic or renal dysfunction, compensated heart failure, malnutrition, elderly, or those on interacting medications. When we're starting a patient on warfarin, the INR shouldn't skyrocket. Make sure we're not overshooting the goal. Each hospital, I believe, has a similar algorithm. Monitoring, of course, is more frequent at the beginning, and then can be pushed out as patients are stabilized. A home monitor is possible if a patient is health literate, and I would say that their INR is typically stable. And I'll mention that there's some recommendations when the INR is too high or if a patient bleeds. Depending on what's going on, we might hold the warfarin or give a dose of vitamin K. But yeah, that was a brief overview of warfarin. Let me know what other medications you'd like to see me go over.